Welcome everyone to this webinar this afternoon on serious illness care, structural racism, and health disparities in the era of COVID-19. We are thrilled that you can join us. My name is James Tulsky, and I'm a palliative care physician, Dana-Farber Cancer Institute in Boston, and also one of the co-chairs of the National Academy's Roundtable on Quality Care for People with Serious Illness. Before we go on, I'd like to thank the sponsors of the Roundtable. You can see here a list of a whole group of organizations that span healthcare providers, industry, professional organizations, and so forth. And the Roundtable on Quality Care for People with Serious Illness is a convening activity of the National Academies that brings together public and private sector stakeholders who all share a common interest, which is improving care for people with serious illness. Typically, the Roundtable holds 2 in-person full-day workshops each year to highlight experts' perspectives on various topics relevant to serious illness care. Over the last period of the last year, as things have been obviously very different, the Roundtable has hosted several brief webinars which have focused on COVID-19 related topics. We've had 2 webinars on keeping nursing home residents and staff safe. We had a webinar on hospital-based palliative care responses to the pandemic as well. These webinars are recorded and they're archived on the website, which you can see listed here on the slide, where all of the webinars are. And yet, no one can live through this last year and not recognize that perhaps one of the greatest impacts of the COVID-19 pandemic has been the disproportionate impact that it's had on communities of color. And this was felt by the Roundtable to be a particularly important topic to address because it also intersects with so much that's been going on in our nation in general, with a much greater awareness of the terrific social justice and health inequities that we face. So that's the motivation for today's Roundtable webinar, and we hope that you'll enjoy and learn. A recording of today's webinar and the meeting materials are going to be available on the event webpage, which you can see here. Please also note that at the end of the panel discussion, there will be time for questions and answers from webinar participants, and that if you're interested in asking a question, please do so. And you can see there's a Q&A function at the bottom of your screen, and you can go ahead and use that. So without further ado, I'd like to introduce the moderator for our webinar today, Brittany Chambers. Brittany is the Associate Director of Education at the Center to Advance Palliative Care, better known to many of us as CAPC. In addition to overseeing the program operations team within the Education Department of CAPC, Brittany also manages the Palliative Care Leadership Centers program and is a co-chair of the Planning Committee and Health Equity Lead for the annual CAPC National Seminar. So Brittany, let me turn things over to you and get us started. Thank you.
Thank you so much. I'd just like to echo James and thank you all for joining us today. I'm very excited to serve as today's moderator on such a critical and important topic. Today, we have the pleasure of hearing from various members of the interdisciplinary care team. They're going to share their individual perspectives and reflect on the experiences of seriously ill patients during this challenging time. We have organized this webinar to be a conversation that will first be kicked off by a short presentation. Our panelists will cover a number of topics, including lessons learned from the first wave of COVID and long-term strategies to help mitigate the suffering for underserved communities. Dr. Zara Cooper will present an overview of this public health crisis, and then we will dive into our discussion. Dr. Cooper is an acute care surgeon, trauma surgeon, and surgical intensivist at Brigham and Women's Hospital, where she serves as Kessler Director for the Center for Surgery and Public Health. She is also an associate professor of surgery at Harvard Medical School. She's associate faculty at Ariadne Labs and adjunct professor at the Marcus Institute for Aging Research, all in Boston, Massachusetts. So now it's my pleasure to go ahead and turn it over to Zara.
Thank you so much, Brittany. And I want to thank Dr. Tulsky and the National Academy of Science, Engineering, Medicine, as well as the Hartford Foundation for this humbling invitation This is a critically important topic, and I'm very excited for the Q&A to follow. What I'm going to do is provide an overview of where we are now. My hope here is that although this is a pretty difficult topic to discuss, I hope that at the end of this, we can think about ways forward and that we can be filled with some hope and optimism. So next slide, please. So right now, I just want to start with where are we today? This is data as of January 26, 2021. There are over 25 million cases of COVID-19 in the United States. In January, we've had 133, almost 134,000 new cases reported, and almost 1.2 million cases in just the last 7 days. And quite frankly, the number of deaths are just devastating. It's really hard to conceive, even among those of us who have had people in our personal orbit who have died of COVID. It's just hard to imagine that over 400,000 Americans have succumbed to this. In mid-January, the United States set a new record for the most COVID-19 deaths reported in one day, over 4,000. Luckily, rates seem to be going down in all states except for Rhode Island right now. But nonetheless, the impact of this has been absolutely staggering. Next slide, please. This slide shows daily trends in the number of COVID-19 deaths. On the left, looking at the moving day average for COVID-19 cases, and then looking at the number of deaths on the right. There are a couple of things that I want to point out to you here. The first is that if you look at the number of cases in the second wave, it's really, in the first wave, it's really dwarfed by the number of cases in the second wave. And if you think about how traumatic that first wave was for so many of us, it's hard to imagine that this second wave is worse. The next thing to look at is that if you compare the number of deaths in the first wave to the number of deaths in the second wave, you can see that the number of deaths, the proportion is not as high as the number of cases. That's for a number of reasons. The number of there's more testing right now, so the denominator is higher. I do think that we have better treatments, but I think we also have to look at the sobering possibility that the most vulnerable among us have actually already been affected in the first wave. Next slide. So today we're going to talk about an overview of COVID-19 and what's been happening with respect to racial and ethnic disparities, disparities in socioeconomic status, disparities in urban versus rural populations, palliative care, and the crisis standards of care, which unfortunately are becoming more and more proximate as the numbers of deaths and hospitalizations rise in parts of the country with limited resources. Next slide. We know that the COVID-19 pandemic has disproportionately affected communities of color, highlighting long-standing health disparities and exposing the pervasiveness of structural racism in healthcare. Explanations for the disproportionate burden include comorbidities, underlying diabetes, cardiovascular disease, higher rates of asthma, HIV, morbid obesity, liver and kidney disease. And we also have to think about the fact that racial and ethnic minorities are more likely to live in urban settings and more likely to have crowded conditions and employment that prevents social distancing. Next slide, please. This was an early landmark study in the earlier phases of the pandemic that looked at the association between race and ethnicity with respect to hospitalization and mortality among patients with COVID-19 who are living in New York City. And it seems a very long time ago now, but if we remember in the earliest phases of the pandemic, when these disparities were first noticed, some of the old tropes came back, that somehow Blacks and Hispanics had genetic predisposition, even though we know that there's really very little genetic basis for race. We know that race is a social construct, that Blacks and Hispanic were somehow physically weaker, and that's why they were succumbing to COVID-19. And so this study looked at almost 10,000 patients from over 200 primary care practices affiliated with NYU in New York City. And they found that Black and Hispanic patients were more likely to test positive. However, among those patients who were hospitalized, they were in fact less likely to die and less likely to have severe illness. And therefore that shows that predisposed weakness doesn't really exist. And that the reason why they're testing at higher rates is because the social conditions in which they find themselves predispose them to that. Next slide, please. This is data that shows that how COVID-19 disproportionately affects community of color. And this was data that was interpreted by NPR that was ascertained from the Atlantic Magazine's COVID tracking project, which I would say, if you're interested in this data, is probably one of the best repositories of this data that exists. What I want you to notice here as we look at the states, I'll show you here, we look at areas that are gray that have insufficient data. So that means that those are states where they're not tracking data by race and ethnicity, and therefore we just don't have enough data to figure out how COVID-19 is affecting populations. That's a big problem. We look here at the areas that are in green, and those are areas where minorities are suffering from the effects of COVID-19 less than they are in proportion to the overall population of that state. But then if we look in yellow and orange and bright orange, we see here that those are areas, which is the vast majority of the country, where minorities are experiencing COVID-19 in higher numbers than the proportion of their population would suggest. So if you look here at this table on the right, if you look at Louisiana, for example, Blacks account for 32% of the population, but were 47% of the deaths. I think that the data from Illinois and from Michigan in particular are staggering. In Illinois, Blacks account for 14% of the population and almost twice as much percent of the deaths. In Michigan, it's almost 3 times higher. And this analysis also found similar results for Hispanics, Latino infection rates, also found that Native Americans were disproportionately effective and that whites and non-Hispanics had rates that were disproportionately low. Next slide, please. This is data that shows from the CDC that shows COVID-19 mortality among Native Americans, American Indian and Alaska Natives. American Indians and Alaska Natives are in the light blue on this bar graph, and whites are in the dark blue. Here, I think you see that the COVID-19 mortality rate overall among American Indians and Alaska Natives was 1 times as high than for non-Hispanic whites. The mortality was higher among men than women. But the greatest disparity here is actually among the young, among those who are 20 to 49 years, which shows that there's a disproportionate number of years lost as well. So the impact on these communities really for generations to come is really quite staggering. Next slide, please. And so we need to consider that, you know, socioeconomic and COVID-19 are really inextricably linked. The socioeconomic status influences housing conditions, accessibility of good nutrition, quality of education, employment opportunities, occupation type, ability to work from home, access to healthcare, use of public transportation, and it goes on and on. And so if we think about all of the ways that these things impact COVID-19, in fact, you know, intervening at the level of healthcare, it's too late. You know, we really haven't laid the foundation to really take care of these people. And so out of all high income countries, the United States spends the most on healthcare and has the worst outcomes. The mismatch between healthcare spending and poor health outcomes can really be explained by the principal disinvestment in the underlying forces that shape health, like education, housing, food security, and also employment, public safety, the environment, and public health. And so this pandemic has only further illustrated how we are not making proper investments really to account for emergencies. Next slide, please. So not all Americans are at equal risk for COVID-19. I think we've made that clear. These were 2 of the first studies that actually looked at the impact or the association of poverty on COVID-19 rates and also socioeconomic characteristics. This first study looked at the association between poverty, hospitalizations, and all-cause mortality. It included almost 3,600 patients in a New York City health system with COVID-19. And what they found was that the patients tended to be younger. The patients who lived in high poverty areas were younger, had a higher prevalence of comorbidities, were more likely to be female or minority, compared to those who are living in low poverty areas. And again, this goes back to the devastating effects on these communities for generations to come. These are young lives lost. These are years of productivity. And it's critically important to consider that as we think about ways to move forward structurally as we emerge from the pandemic. Again, looking at the impact of neighborhood socioeconomic characteristics, these investigators used something called the Area Deprivation Index, which is an aggregate measure of socioeconomic vulnerability. And again, they found that the COVID-19 prevalence was higher in high ADI zip codes as opposed to low ADI zip codes. Next slide, please. This is a quote from Charles Blow, who is one of my favorite columnists from the New York Times and really a very provocative social commentarian, especially with respect to race. This was an article, this was an op-ed that he published back in April, which I want to point out to you is before George Floyd was murdered. And so before kind of the social and racial unrest that brings us to where we are today had really started to emerge. He said, in a nation where too many Black people have been made to feel that their lives are constantly under threat, the existence of yet another produces less panic. The ability to panic becomes a privilege existing among those who rarely have to do it. I wholeheartedly encourage everyone who can to stay home, but I'm also aware enough to know that not everyone can or will, and that it is not simply a pathological disregard for the common good. And the reason why I share this quote with you is because I think that in the early phases of the pandemic, there was a lot of finger pointing towards communities of color who really didn't have the defenses that they need to protect themselves. There was a lot of accusations that they just weren't staying home or adhering to social distancing and good public health practices. But unfortunately, that's just not the truth. They're just unable to because of the circumstances in which they find themselves. I think the other thing here that I found really striking is this line, the ability to panic becomes a privilege existing among those who rarely have to do it. And quite frankly, in looking back that he wrote this in April, I think that this is actually prescient. I think it really is striking for those of us who live in privilege, who have been able to protect ourselves from this, that in fact, that panic that we experience is something that's very unfamiliar to us and is unfortunately incredibly familiar to large numbers of Americans. Next slide, please. This was data that I found to be very telling and also frankly heartbreaking. I am a native New Yorker. I grew up in New York City. I went to medical school in New York City. It's hard to find a place where economic disparities are in greater relief, quite frankly. And this was data that was published and analyzed by the New York Times, which showed that patients who were treated at some of the community hospitals in New York City were 3 times more likely to die as patients who were treated at medical centers in the wealthiest parts of the city. This is a quote from Dr. Carol Horowitz, who's the director of the Institute for Health Equity Research at Mount Sinai. And she said certain hospitals are located in the heart of a pandemic that hit on top of an epidemic of poverty and stress and pollution and segregation and racism. And we see that borne out in the mortality rates that these different hospitals experienced. For those of you who aren't familiar, Manhattan is home to some of the largest, wealthiest, and most prestigious academic medical centers in the world, quite frankly. And many of their patients are wealthy, they're educated, they're white. Most of the outer boroughs where many of minority patients live are serviced by kind of this hodgepodge of centers, of city hospitals. And so there was a dramatic difference in where different patients were receiving care. Underfunded community safety net hospitals often face lower numbers of staffing, worse equipment, and less access to drug trials and advanced treatments compared to private academic medical centers. And if you look here, I think this is so dramatic and really so telling for an urban environment. If you look at this map here, this shows near the area of 30th Street and First Avenue, which is where NYU Langone, the flagship hospital, is located. That's in the purple star. It's only blocks away from Bellevue Hospital, which is the largest city hospital, which is also run by, is also a teaching hospital of NYU. But if you look here, the mortality rate at NYU Langone was half that of Bellevue. That's pretty dramatic. And so there were some, policy academics at the New School, Center for New York City Affairs, who suggested some remedies for this to really prevent this kind of disparity from happening in the future. They suggested that the governor needs to rescind the Medicare cuts. The Medicaid cuts. They also suggested that healthcare should be extended to all New Yorkers, regardless of citizenship status, recognizing the close proximity that New Yorkers have to people of all types, right? That the state should implement the governor's announced integrated hospital program. What does that mean? That means that scarce resources would be allocated according to community need and not necessarily who clamors the loudest. That the state legislator should consider capturing excess revenue of nonprofit hospitals, right? Because most of the large wealthy academic medical centers are in fact nonprofit hospitals that enjoy considerable tax benefits because of their status. And that most critically, the state and city governments need to commit to equity. And actually their recommendation was equality, and I put in equity because I think that's even more important. I bring these up because I don't think they're unique to New York City. If we're going to prevent this from happening in the future, we need to think about this on a national basis. Next slide, please. Next slide, please. So this is a diagram that shows COVID-19 in rural versus urban populations. And what I want to point out here is that if you look at the large urban population that's in the dark black line, and you compare it to the micropolitan, or which is in the lower blue dashed and dotted line, the first part of this pandemic was really an urban phenomena. There were reports on TV where you would hear citizens from other parts of the country who had not yet been affected saying that's a blue state problem. That's not really our issue. The tide has turned here. And what we see is that, while overall in the aggregate, the urban locations have been hit the hardest, there's been a switch. And in the later parts of last year, the numbers of rural patients started to rise. Next slide, please. Why is this a problem? This is a problem because rural communities are uniquely vulnerable. They have higher levels of poverty, they have fewer job opportunities, they have heightened vulnerability to the labor market, they have less access to healthcare, heightened reliance on telehealth, they have older and more health compromised populations. They face barriers to enrollment in clinical trials. They're not getting the cutting edge treatment because most of the academic centers are in urban environments. And they also had limited access to COVID-19 testing. So these were major problems. And part of the problem with the location of academic versus non-academic centers is that much of the research that has been done on COVID-19, in part because of the cadence of the disease and that it was slower to reach rural populations, but also because of the interest of the academics who are studying this, means that we don't have a complete understanding of COVID-19 in our country. That our understanding of COVID-19 is disproportionately favors urban and suburban populations as opposed to rural places. Next slide, please. One of the things that's also important is if we look at differences in urban versus rural bed capacity. This is a diagram here looking at the hospital beds per 10,000 population by metro and non-metro areas. And here, again, non-metro populations tend to be older and sicker. And after adjusting for population age and other variables, we can see that non-metro and metro areas have a difference. In non-metro areas, there's 1.6 beds per adjusted age population versus 2.9 beds. So that's almost a doubling. That's almost a doubling the number of hospital and ICU beds that are available. And in summary, non-metro areas have about 10% fewer hospital beds per age-adjusted 10,000 population, which also puts increasing pressure on those health systems to provide care for their patients, and unfortunately puts them in a position where they need to consider crisis standards of care, which we'll talk about in a moment, and really the potential of rationing care for their patients. Next slide, please. So I will say that I think that in COVID-19, palliative care met its match, but I would also say that palliative care met its moment. This is a quote from the American College of Surgeons statement on palliative care, and I read it in part because I'm a surgeon, so I have my biases, but also because I think that it really summarizes nicely why that is. Palliative care aims to relieve physical pain and psychological, social, and spiritual suffering while supporting the patient's treatment goals and respecting the patient's racial, ethnic, religious, and cultural values. So important as we think about all of the different influences that COVID-19 has. Like all good patient care, palliative care is based on the fundamental ethical principles of autonomy, beneficence, non-malfeasance, justice, and duty. And I think here, when we think about the type of medical care that patients with COVID-19 need, this is exactly it, you know? And so during the pandemic, palliative and hospice patients face symptoms, emotional distress, decision-making in the face of terrible uncertainty and limited options. I mean, caring for hospice patients in the setting of, you know, this unknown and out of control pandemic, we know that over 6,000 patients have died in hospice. Patients with COVID-19 have died in hospice. The consideration about how we need to change the way that we deliver palliative care in the inpatient, outpatient, and hospice setting have really been staggering. Nonetheless, due to, you know, our expertise and training, palliative care providers are uniquely suited to address these challenges. Next slide, please. But we also know that even before the pandemic, we were unable to meet the needs of the numbers of seriously ill patients in this country. The palliative care consult teams are a limited resource. And so primary palliative care really had to become the moniker of the day, that it became the responsibility of every provider caring for seriously ill patients to be able to deliver palliative care. It was a crash course for many. It also meant that the palliative care consult criteria needed to become stricter, so that some of those patients, the seriously ill patients that maybe we'd been seeing on a longitudinal basis who didn't have such acute needs, couldn't get the type of palliative care that they needed in the moment to favor patients with more acute needs due to COVID-19. We needed to limit the number of palliative care providers who had direct contact with the patient. That was true for all providers. I'm also an intensivist, and so I was taking care of folks in the COVID unit. It was really difficult to care for patients, quite frankly, who were prone much of the day. We had never seen their face. We didn't know what they looked like. We didn't know who they were. And yet we were having conversations with their families on iPads and tablets, families that we never met, families that we were never able to make that initial connection with, and having very difficult serious illness conversations about prognosis for a disease that we really didn't understand. We also needed to discourage existing palliative care and hospice patients from coming to the hospital. And so that also became very difficult. Preparing for healthcare in the context of scarcity, many of us very early on in the pandemic were starting to worry about what we were going to do when our demand outstripped the supply. And we needed to utilize evidence-based communication curriculum to prepare other clinicians to have difficult conversations. And there were resources from CAPC and from Vital Talk. I know I use them, including blogs, apps, pocket cards, videos, courses, and like many, I think many of us in this pandemic, palliative care services became very resilient, became very nimble, and met the needs of their colleagues in doing kind of on-the-fly training. We had a number of training sessions here. One of our palliative care clinicians created an app. And so there was lots of innovation that happened to improve the type of primary palliative care that we could deliver. Next slide, please. But I would posit that it was actually more than that, that for clinicians who weren't palliative care clinicians, we really needed to have an overall frame shift in our thinking about palliative care. For many non-palliative care clinicians, they still think about it as something that's only reserved for the end of life, and don't think it holistically about how to integrate palliative care into all aspects of the care that we deliver. But my colleague Rochelle Bernacki and I wrote this editorial for JAMA Surgery, basically saying, for example, that for surgeons, we really need to embrace all the principles of palliative care in order to take care of our patients. Using serious illness communication strategies to disclose prognosis and establishing goals of care. This entails, one, understanding that serious illness communication strategies exist, and two, that prognosis and goals of care are the place to start. They're a starting point during admission. Understanding conceptually the treatment of total pain, including psychological, social, emotional, and spiritual pain that comes with having an imminently life-threatening condition. And then caring for the family unit. Again, as I described these patients that we cared for, we didn't know the patient. And the only exposure we had to the family was via a video screen, like I'm with you today. We really had to think holistically about all of the stakeholders and players here. We were also, particularly at the early phases, dealing with a lot of the grief and guilt of family members who had infected their loved ones who became so ill. And so there were a lot of psychological dynamics that couldn't be separated just from clinical care alone. And this was a paradigm shift for many of us who are not palliative care clinicians. And then I think another really important thing that's come to bear is the importance of supporting clinicians. I think that palliative care of all clinical fields has really been on the forefront of preventing burnout and promoting wellness among its workforce, recognizing that dealing with seriously ill patients day in and day out can be emotionally and psychologically grueling, as well as very, very rewarding. And so putting processes in place to support clinicians are critically important. And we know that clinicians, unfortunately, rates of suicide among medical trainees and medical doctors has gone up over the course of the pandemic. So we know that there has been profound psychological toll here. Next slide, please. I do want to say that I feel like this is working, that this is a quote that was just published in the American College of Surgeons Bulletin by Lena Napolitano. She is the director of critical care and the Macy Foundation Professor of Surgery at the University of Michigan. She's also a member of the American College of Surgeons Board of Regents. And this was a quote that was published in the Bulletin this month. The American College of Surgeons is the largest professional organization for surgeons. This is something that goes out to over 50,000 of us. It wields quite a lot of influence and power in our field. And she said, post-operative mortality, 4.2 million patients a year, is difficult and is higher with COVID-19 infection. It's particularly challenging during the pandemic, with families unable to visit their loved ones. Hospitals have had to make difficult decisions to balance minimizing COVID transmission with the provision of compassionate, high-quality patient care. As surgeons, we are healers, and the ultimate goal is to provide patient-centered surgical care to improve health and life. But when perioperative mortality is looming, we help patients and families make end-of-life decisions. The bond and trust patients have with their surgeons has never been more important. And as surgeons, we have an important role in providing care and support for our dying patients. They will not die alone. And so this signals to me that we are taking the torch, that those of us who are not practicing palliative care primarily, who are not on palliative care consult services, are recognizing the importance of applying palliative care principles in other disciplines. Next slide. So I want to turn momentarily to the crisis standards of care. And this is intended to provide a framework for a fair allocation of scarce resources during emergencies. It's based on ethics, the rule of law, the importance of provider and community engagement, and is really intended to permit equitable and fair delivery. The key principles include fairness, duty to care, stewarding resources, transparency, consistency, proportionality, and accountability. I think the question is, can we do this in an equitable way? Next slide, please. So this is a diagram here of states that had crisis standards of care in place in the earliest phase of the pandemic. This was a study, a systematic review of 29 publicly available state-level crisis standards of care that found wide variability and in their existence, but also in their specificity, and highlighted major concerns that crisis standards of care could disproportionately impact disadvantaged populations due to inequity in comorbid conditions, prevalence of expected lifespan, and other effects of systemic racism. In this systematic review, they found that some states didn't even have them. So in the taupe, I guess, you can see that some states don't even have them. In the dark blue, some states had specific crisis standards of care. But again, in those states that don't have them, or where they have crisis standards of care in development, it puts patients in a very precarious situation because they will be evaluated for their fitness for treatment by subjective criteria, by highly subjective criteria. There was a tremendous variability among those crisis standards of care in that 10 considered societal value or the patient's value to society as one of the measures. I'm not sure how you evaluate that. And 15 considered comorbidities, which of course disproportionately fall on disadvantaged populations. Next slide. One of the major ethical challenges was the concept of lives saved versus life years saved. A focus on life years saved will disproportionately negatively impact people of color because they have lower life expectancy to begin with. And so you will never have as many life years saved if you compare a 12-year-old Black boy to a 12-year-old white boy. Additionally, incorporating comorbidities and long-term prognosis into scoring schemes becomes very problematic. How do you think about a 35-year-old with chronic kidney disease who just started dialysis? And of course, those patients are much more likely to be Black and Hispanic. The other issue came up was prioritizing healthcare workers. There were some crisis standards of care groups that thought that it was a quid pro quo, that the frontline healthcare workers had really put themselves forth and then deserved something in return. At the same time, we have to consider that healthcare fields like medicine and nursing have for centuries systematically excluded Blacks, Hispanics, Native Americans, and others from entry into those professions. And therefore, again, it disproportionately impacts patients who are disadvantaged populations. So we have to think about all of those ethical challenges. The practical challenges included timely dissemination of information, and I would say certainly in this climate, making sure that there's not misinformation. I think many of us are aware of the historical mistrust that minority, particularly Black community, has about healthcare. And so there is rampant misinformation. We know that this is happening with the vaccine trials and the vaccine administration. And then of course, social distancing, which makes it very difficult to do tabletop exercises, which are required to really anticipate, to display like how all of this could really work in real time. And so it means that when the crisis of standards of care kind of go into play, simulations and models haven't really been worked out in the most rigorous way that they could be otherwise. Next slide, please. I would say that, in certain parts of the country, the pandemic is just absolutely on fire. There are very high rates in Los Angeles. Right now, 1 in 5 patients and individuals in Los Angeles who are getting COVID tests are testing positive. And there's expectations that crisis standards of care could be put in place imminently. So these are not remote. I think as the second phase of the pandemic gets worse, we really have to keep this in mind, and we have to think about our role as palliative care providers and providers who care for seriously ill patients. Next slide, please. So in conclusion, I want to say that I think that the lessons learned here, of which there are many, these are a few, but that I hope can start off our discussion, is that we need comprehensive data by race and ethnicity. You'll recall earlier in the presentation, I showed that there were quite a few states who were not collecting this data. And so it becomes difficult for us to anticipate what the needs of our population are. That the social determinants of health really have to be at the heart of all health policy initiatives. To those of us who are public health researchers, that's a no-brainer, of course, but we really need to put this into our policy, put this into how we think about healthcare delivery, that in fact, we can have the best hospitals in the world, we can pay the most money in the world, but without a population that has had the advantages of the best education, the best nutrition, the best childcare, the best employment opportunities, that best healthcare system doesn't really meet the mark. That we need broad interdisciplinary work examining the needs of rural patients as well as urban patients, that we need to incorporate palliative care into all phases in the intermediate and the long term, in the immediate and long term, to optimize care and also to relieve suffering, and that we have a duty to plan, that being in the middle of a pandemic and not having crisis standards of care in place is not enough. And there are many of us in this audience who could be at the forefront of helping us plan for the future. And so with that, I want to thank you very much for your attention, and I look forward to the panel discussion.
Thank you so much, Dr. Cooper, for that excellent and informative presentation and just laying that groundwork for the conversation to come. So now I'd just love to introduce our other incredible panelists. We have Dr. Karen Bullock, who is the professor and head of the School of Social Work at North Carolina University. We have Dara Duncan, who's a certified hospice and palliative care nurse and member of the palliative care team at Mount Sinai in New York City. And we have Reverend Dr. Jeffrey Garland, who's a chaplain at the VNA Health Group Barnabas Health Home and Hospice and Palliative Care Center in New Jersey. So welcome you. Thanks all for joining. So I'd like to start with a question that will get at kind of your reflections and observations of the impact that COVID has had on communities of color, both at the national scale, referring to what Dr. Cooper just presented, but also what you observed on the local level at your own organizations. And if I can, I'd love it if Dara could kick us off.
Hi, good afternoon. Thank you for having me. So it was observed by myself and colleagues from other health systems here in New York City that patients were being treated in terms of who received experimental treatments for the COVID-19 virus. For some patients, experimental treatments such as convalescent plasma was pushed on them, while others, they weren't. Generally, Black and Brown patients, they weren't considered for certain treatments. Nurses and patients' family, it was like we almost had to beg for them to get the treatments, and it was like they were ignored. It added a lot of moral distress on top of what was going on during the pandemic, especially as a palliative care nurse, seeing patients die alone and the stresses and anxiety that the pandemic brought. It was really hard, you know, and there was this overall desire not to cause conflict against the need to advocate for patients, trying to, you know, not create further stresses or anxiety. And it was felt that we may have fallen short. But we're hoping that with new spotlight on this current disparities, my colleagues and I, we can move forward with being more vocal, asking questions when potential biases are being observed, and emphasizing on shared values of ensuring equitable patient care for all, which is one of the core values of my organization.
Thank you for sharing that and the transparency. I really appreciate that. Jeffrey, do you mind commenting? Same question for you.
Hello, good morning or good afternoon, or hello wherever you are in whatever time zone. I want to thank Dr. Zora Cooper. She pretty much filled in everything I wanted to say as it relates to disparities and inequities. But I would like to acknowledge that bias and inequities in the healthcare system and the disparities were a part of the Black and Brown communities long before COVID-19 arrived. It has been well known for many years that Black and Brown communities are predisposed to living and working in communities that do not support healthy medical decisions or socioeconomic or educational outcomes. Black and Brown communities have a higher pre-existing history of chronic comorbidities, such as hypertension, obesity, diabetes, and poor health care choices. Because of the pandemic, it is important to acknowledge that Black churches play a major role in coping and resiliency and providing care to Black, Indigenous people of color in their communities. Due to the pandemic, the lack of physical access to attend church in a building with physical fellowship was hard for our communities. Attending church physically is not only just about the spiritual or the religious care, but it also provides a substantial mental support as well. Spiritual care, especially attending church, can be a cathartic and therapeutic function, specifically for those who are living with serious illnesses. It adds another level of support during an already challenging time, and clinicians should be mindful of this issue and develop appropriate management plans with and for older citizens in Black and Brown communities. Thank you.
Yeah, thank you for that insight and for touching upon the importance of spiritual care. I couldn't agree with you more. So now I'd love to talk a little bit about what you all think that health systems and organizations can be doing to better support clinicians who have this dual experience of, being a member of the community that they are having to treat and care for. And Dara, I'd love if you could chime in first.
Sure. Thank you very much. I think one of the major challenges here is that, clinicians of color live in this dual reality. I think on the one hand, we are part of health systems, we are in revered professions, we are educated, erudite, we hold prestigious positions in our communities and at the hospital. At the same time, we live in this other reality where we are in a different caste, quite frankly. And I have to be honest that I have never felt so Black in a bad sense as I did during these last few months. And what do I mean by that? I mean that it has never been so clear to me that I live in a society that, because of the color of my skin, doesn't care that I am disadvantaged, despite my education, despite my economic status as a surgeon. My life expectancy is still lower. My risk of breast cancer is still higher. The chances that if I had a son, he was more likely to go to jail is still higher than my white counterparts, and even white counterparts who haven't achieved what I've achieved. And that is just terrifying. And so living with that, processing that, while we're also dealing as clinicians on the front lines and caring for patients who are dying because of those same effects of the social determinants of health, and quite frankly, of racism, is just devastating. And so the psychological, tools that we have as individuals to kind of keep on going on in normal times, have just really, in many cases, just fallen apart. And so I think that the health systems need to acknowledge that. I think they need to understand that. I think our coworkers need to appreciate that. And I think we also need to create fora for discussions about it, for understanding. I think one of the biggest challenges that I've experienced, and that I would imagine that many of my other colleagues of color have experienced, is just kind of this unknowingness, this lack of recognition of the undercurrents of racism. I don't want to say the tsunami of racism that's affecting this disease, and just feeling like you're living in an alternate reality because people aren't feeling and experiencing what you're feeling. And so I think the opportunity to kind of bring our colleagues along on that, not in an accusatory, but in a curious and compassionate way, I think setting up those fora are critically important for maintaining the health of the psychological and, quite frankly, physical health of our workforce.
Absolutely. Thank you so much for naming what I agree a lot of us are feeling right now. Dara, did you want to comment and share on this topic as well?
Well, I feel that clinicians of color could have been supported by more by health systems, providing programs that can help them deal with emotional and psychological, the toll from the pandemic. I feel they were affected more than their white counterparts. They not only had to deal with the horrors of the pandemic as everyone else had to, they're part of the community that was affected most, and much more likely to know people that have died from the pandemic. And that creates a huge amount of personal grief. And our health system could have done much better to provide targeted support to just clinicians of color, that group. Also, I think they could have helped with resources to help the clinicians of color get to the community and help educate them by providing resources, or probably just highlighting achievements of these clinicians and celebrating them within the community, and possibly creating more trust within the community. It'll be easier to educate about COVID-19, the virus, the vaccination, the importance of being vaccinated, and it would help to combat COVID-19.
Yeah, thank you for sharing that. I do agree that it's important that we hold our organizations accountable. naming these things that they've missed in the past and, you know, standing firm that we need more support, you know? So I totally agree with that. I'm wondering if we could flip a little bit and talk about some patient care aspects as far as the racial data collection and the reporting and the dashboards that we're seeing and how those can inform interventions. And if any of you have things going on at your own institution that you could share, I think it would really help our audience. So Karen, I'd love to hear from you.
Okay, great. Thank you, Brittany. As I listen to the other speakers who've gone before me, my head is just sort of spinning. I can enter into this conversation in so many different ways. I can completely relate to Dr. Cooper and sort of the intersectionality and being in the various professional roles, but also the sort of what I refer to as racism fatigue, if you will, that I was experiencing or have been, still am experiencing since the COVID-19 pandemic that Dara talked about. So I think that it's really critical that we think about aggregates and, you know, sort of data collection, as Dr. Cooper so eloquently demonstrated in her presentation. It's really important to know how various populations are disproportionately impacted by structural racism. And many of my social work colleagues and we've been having conversations about, you know, what is the difference between implicit bias and racism, and this whole sort of reframing, if you will, and reimagining kind of how we can use our language differently as we try to engage various populations who historically have not been very welcoming and included in our efforts. And the whole notion of structural racism, which I think of as the social determinant of health. I mean, we've all ingested racism, and so we sort of own this language that we use now as we talk about race as being a risk factor. But I would like to reframe things and say it's not our race or our phenotype that's the risk factor. It's actually the racism that is actually the risk factor. And so what's actually the social determinant of health is the structural racism and not the color of my skin, because the color of my skin is not really impacting, if you will, whether or not I'm going to get a good education or be able to live in a community where, you know, I have an environmentally safe environment. So that's not happening because of something within my phenotype. It's happening because of the structural barriers that historically have been put in place for communities and in communities like those that I live in and that I grew up in. And so this creation and sustainability of these barriers is what we're experiencing now, and to the point that was made about, you know, Black and brown people were disproportionately impacted even before COVID-19 pulled back the layer, if you will. So in terms of racial data collection, I think it is important. We need to know disproportionately how our communities impacted. But each of us, probably in the audience, and I certainly on this panel, realize that, you know, people of color, Black and brown people, are less likely to participate in the data collection, in the research, in the same way that we're struggling with how do we get people to feel comfortable with the vaccine. And we need to look historically at why that is. And we don't have to look very far to figure it out. It's the legacy of the historical racism in this country. So I think the data collection is important, but I also think that it's essential for us to use lenses that we haven't been using heretofore and sort of rethink the conceptual frameworks that guide our research and our data collection, and start to incorporate these frameworks that focus on historical racism. And certainly as we think about contemporary medicine, we all know that it's rooted in systemic racism and the inhumane treatment of enslaved Black people in this country. But even before enslaved Black people were the indigenous people who were here before. And so if we look at, you know, this disproportionality that we talk about, it's not because of something that the individuals have been doing to themselves or to their community. It's the structure that has created these divides. And so I think it's necessary for us to shift the frameworks, the lenses through which we think about data collection, the way in which communities think about experimentation and research and vaccines, which is all rooted in actual experiences historically of people in their communities. And so I'll stop there.
Yeah, Karen, that was great. That was really great. Thank you for saying all of that. You know, I can give you examples of how we have started to incorporate race, ethnicity, and language data into the data we collect at the hospital level to affect change in treatment. So one example is that during the first wave, we started looking at our COVID mortality by race, ethnicity, and language. And that was incredibly important because we actually didn't see a difference. And that was really very telling for, you know, all of our constituents, our clinicians, our hospital workers, our larger community. You know, historically, Brigham and Women's Hospital has not been known as a beacon of anti-racism. You know, we have a very troubled and checkered past, quite frankly, in the city of Boston and in our own community. We are situated in Roxbury, but most of our patients are not from Roxbury. They won't come here. And so being able to say, you know, we're taking care of everybody and everybody is getting the same treatment and having the same outcomes, I think was really important for us. The other thing is we looked at our surgical depot. And what I mean by that is that, as many of you may recall, surgical procedures were put on hold, and quite frankly, they're on hold again. Elective surgical procedures are on hold again during this second wave. And we looked at the patients whose cases had been postponed by race, ethnicity, and language to make sure that there was equity and access to getting those procedures when we resumed doing elective surgery. First of all, I was thrilled that anybody was thinking of that. And second of all, it allowed us to do some targeted outreach, because what we noticed was that our Black and Hispanic patients were not coming back at the same rates as our white patients. They didn't feel as safe, and so we could do targeted outreach. The other thing, quite frankly, is that what we discovered, which we hadn't looked at before, was how out of whack our numbers were, that the numbers of Black and Hispanic patients that we treat relative to the community where we sit was abysmally low. And so in looking at that data, there's just no way to deny that we've got to do better and we've got to figure it out. We've got to figure it out fast, right? We cannot call ourselves a not-for-profit organization that's servicing the state and the city of Boston with those kinds of numbers. It's embarrassing. It's embarrassing. And we can call that out now that that data is there. The other thing we've been doing is we've been collecting the vaccination rates also by race, ethnicity, and language. And unfortunately, and not surprisingly, we are finding that, that a greater number of our relative, proportionately, our Black clinicians and Black healthcare workers are not getting the vaccine. And again, you know, it's not mandated, but we've been able to go to them and figure out why. You know, and what we've heard is, you know, I'm waiting for a better vaccine to come along, and we can say to them, actually, the data is not bearing out, and get these early vaccines, because the other vaccines that are coming along don't seem to be quite as effective. But again, it allows us that targeted outreach. So I do think that data at every level, at, you know, the hospital level, the local level, clinician level, whatever it is, puts things in stark relief. And you know, I guess sunlight is the greatest disinfectant, right? I mean, that's the way to really start moving the needle on some of these things.
If I may add, I want to thank you, Dr. Cooper, for the use of the language Black populations. I've talked to many patient populations and communities. When we use language to refer to cultural groups like African American, for example, that's not very inclusive language. Many of my colleagues who are Nigerian or from Haiti or they don't identify as African American. And so when we use language that is not, that the individuals themselves don't see them a part of, that creates another barrier. So figuring out how to refer, so if we're going to refer to race, yes, the race is Black, but if we're going to refer to cultural groups and we only use African Americans to refer to Black people, then, you know, Jamaican people with Jamaican ancestry is very different. And so if we really want to focus on the people who need it the most, we've got to be inclusive and sort of deconstruct this language and allow people to see themselves in the work that we're doing. And that hasn't happened so much to this point. So thank you.
Thank you, Karen. I appreciate you taking the time to talk about the importance of the language, because it really does matter. And so now, thank you, and thank you, Zara, for talking about the REAL initiative at your institution. And related to that, I wanted to talk through just some known models to help ensure access and use of health services for all seriously ill patients that we know are working, just because we don't want to continue to leave certain communities out. And we do want to highlight things that organizations should invest in and governmental organizations should be thinking of. And Jeff, if we could start with you, I'd love to hear about some of those models that you're aware of.
One of the models that I'm aware of is faith-based webinars to facilitate dialogue and promote better coping with mental health issues and discrimination and loss during the COVID-19 pandemic for Black communities. I've also heard of spiritual hotlines to virtually assist spiritual needs of its people, including those of different religions and nationalities, to deal with challenges that we're facing now. However, to truly address structural racism and the historical absence of government, corporate institutions must invest in faith-based communities for extended period of time. COVID-19 has impacted the Black and Brown community patients disproportionately by institutional racism that continues to plague minority communities. And I also feel as though Black leaders need to take more responsibility. In my particular community, we have the local clergies coming together, and we're offering church space, church parking lots, church space, where we are allowing free COVID testing for people in the community. And now we're trying to get those same locations to allow vaccines to take place, as well as COVID-19 testing. And I just wanted to share with you, trust is still a very, very big issue with us. And I just recently, my wife shared with me that Tyler Perry had something on BET last night, speaking directly for the Black community and COVID-19. And one of the beautiful things about that program was that he had a Latino director from Emory University come on and break down how the research took place. And then he had an African-American sister, Dr. Kimberly Manning from Emory and Grady Hospital, and they spoke in our language. They weren't telling us, they weren't outsiders coming into our communities telling us, you have to put this foreign substance in your arm. They were telling us how it was made, what are the side effects, how it was created, and what are the after effects. And the most powerful thing that I came away with was not that they knew all the answers, but they were truthful enough to say, I don't know. I don't know where this is going to end. And to me, that showed me more power through truth in saying, I don't know, rather than the traditional, we're coming into your neighborhood telling you what you need to do.
And thank you so much for those comments. I would like to echo your points about the mistrust and how important it is to have trusted representatives, as so many of you have already said today. As we think about, if we wait until people are critically ill, for example, diagnosed with a serious illness, or perhaps non-curable illness, and this is the time in which we want to convince people that we will take good care of you. Or during a pandemic, and we say, here's this vaccine, we see what's happening to your community, and we want you to have it. We want you to get this vaccine so you can live on. Many of these people, people are asking, well, where was the care and concern before now? Because as we've already spoken about, the chronic illnesses, the pre-existing conditions are part of what put us as populations at risk. So why wasn't someone concerned about preventative care and healthcare and ensuring that there was healthcare for all before now? And so it's difficult for people to believe that there is some sort of benevolent interest in a population that they've not seen evidence that there was interest in prior to this pandemic. And in terms of models, what I found is investing in paraprofessionals and informal supports, such as faith-based communities and others. If we get folks from trusted communities to talk with, just as you've described that Tyler Perry did, we can make more progress. But we also need to be flexible with those models, because many of the models for even integrating or going into communities have not involved those individuals of those communities in constructing those examples. And so I'll use this briefly with end-of-life care, palliative care, which I do quite a bit of work in. So I was interested in understanding whether there are racial differences in a particular hospital that had a palliative care unit. And just as Dr. Cooper pointed out, it was situated in a predominantly Black and Brown community. So when I looked at the retrospective data, I found that Black and Brown people were not dying in that hospital, even though many people we know in the US, most people die in hospitals. So I had to conduct qualitative research. So in terms of models, sometimes we really do need to invest in communities, take it to another level. And so I conducted focus groups with older adults. And what I learned is that those individuals, older adults, Black older adults in particular, are still talking about the Tuskegee experiment, even though younger people think it happened 500 years ago, it didn't. And so it's still very present in their minds. And the fact that just for them, a few years ago, as older adults, they now have access to this hospital setting. But for most of their entire lives, there were lines that they didn't cross. They did not have access to those hospitals. So when we start to say to communities that historically have witnessed these barriers and this structural racism, it's really challenging to convince them that something that the healthcare system has deemed good and helpful, now they want to involve them in it. So I think we have to think about these models that are going to invest in the gatekeepers, and the stakeholders, and these trusted relationships. But lay helpers, I think, are, in terms of your question, Brittany, about models, the lay helpers and folks who can really reach out to the communities that the healthcare institutions otherwise would not, but also understanding the historical legacy within those communities as they relate to structural racism, I think, are critical.
Yeah, if I could add on to that in thinking about some of the conversations that we've had around increasing our vaccine rates at the hospital here. I think one of the challenges is that as a scientifically driven community, we don't respect emotional knowledge as much as we respect data and scientific knowledge. And I'm very data driven, but these are emotional issues. And so, I think one of the challenges is that our emphasis is always, well, if only we could educate, if only they would listen, if only they could know more, if only we could show them. But I think what we need to show is goodwill. I mean, I think we need to show our humility. I think to Jeffrey's point, to Dr. Garland's point, I mean, we need to show that, we are not, that we don't, what we don't know. That mistrust comes from, centuries of hubris on the part of the medical community. And so I think we need to kind of dial it back a notch and kind of level out our respect for the types of knowledge that are at play here.
And if I might add on to your comment, which really resonates with me in terms of the models, we know that in terms of palliative care, hospice and palliative care, we have not done very well in terms of closing the gap. I've been looking at the NHPCO data for the past 15, 20 years, and the numbers don't change very much. It still remains about 80% or higher that are white, and we know that they are underrepresented groups. Yet we continue to perpetuate these models that we know are not getting us any closer to closing that gap. And if we were, just as you said, we're willing to say these models haven't worked, maybe we should hear from them, maybe we should think about these different ways of approaching it, as you said, incorporating emotional and other things. But we have the data that shows us we are still not doing very well in these areas, and we still continue to use these models that don't work.
Great, thank you so much for sharing those insights and reflections. I'm just checking the time, and I do want to make sure that we hear some questions from the audience. So I'll take one now from Sylvie. Thank you, Sylvie. She says, what suggestions could you give to help team members bring light to ways to combat our institutional racism and better support our colleagues of color? So more on a team sphere of influence. Dara, could I maybe ask you to chime in first? Oh, you're on mute.
I feel having possibly focus groups that can bring the team together and learn about racism and how you can combat it on a team level in that setting. Can you repeat the question again? I've lost my train of thought.
Sorry, so she was just basically asking what they could do with their institution to combat institutional racism, and specifically, I think, serving as an ally to colleagues of her colleagues of color.
Yeah. So having groups that you can have the colleagues of color voice their concerns, what's affecting them, how it affects them, and bringing it back to the institutional, back to the institution, and forming an alliance that can help promote an environment that stops racism or helps to alleviate it or stop it, or even, help the people that are affected by it feel more comfortable because of the way they're going to deal with it on that level. If you understand what I'm saying.
Yeah, thank you. So we have another question from Z, and I'm going to actually pose this one to you, Karen. He wants to know, how might we move towards more inclusive language for Black and Brown communities in our research protocols, manuscripts, and presentations?
And I will say that I think that there's evidence that there is a shift already. We can see a change in language. I've been reading some articles of late that it's evident that people are paying attention and listening. And so I think we just need to take tiny steps in terms of, for those of us who are educators, which probably most of us on this panel are educating in one way or another, or training, have training programs, et cetera, but to be mindful of this language. Some colleagues and I are working on an article now, but not everyone is writing and doing research and studying, but we're working on a meta-analysis. And so we're looking at years of publications to look at the language so that we can be informed, evidence-based practice, of course. So we want to look at the language and look at the way we're talking a lot in medicine, everyone is in healthcare in general about person-first language. I'm sure you're all hearing it. So people are not their diagnoses, right? And so as we're having those shifts, it opens up this opportunity for us to look at language and say, okay, well, where else can we be more person-centered? And if we start to look at labels that we use for communities, like for example, many of my colleagues will say, I've heard them say, I work in a majority minority community. Well, if it's minority, it's minority. I mean, how is it a majority minority community? But that's just language that we've all ingested. And so I think in terms of the response of how each of us has to become consciously aware, once we're consciously aware, we will start to think about it when we write, when we speak, and it can be reinforced in our practice settings, in our webinars, educational settings, continuing education. We all can make a difference. We don't have to have this one coalition of the willing. Each of us can take steps in the direction of changing language.
Thank you for that. We have another question from Morgan, and she wants, she states that she knows that some states have started to develop minority health advisory boards. And she just wants to hear from you all if you know if there's any evidence that those type of initiatives or boards actually do help to improve access for communities of color. So I'll pose that to anyone on the panel to answer.
I personally think it matters if it's supported from, or if it's supported or enforced from a board of directors position. I'm finding on different committees and organizations I'm members of, you could form a committee, but if it's not going to be enforced by the board of directors, if it's not going to be placed into bylaws, if it's not going to be listed as an annual or biannual review, we're just wasting our time. And I just like to personally say that as a Black African-American male, this is becoming exhausting because and also as a marriage and family therapist, I want my white brothers and sisters to understand this. When we tell our stories, or I'll speak for myself, I should say, when I tell my story of growing up in Miami, Florida, in a racist town, at the age of 12, I had to get a police card because no blacks were allowed on Miami Beach after 5 p.m. without a police card, and the police card was nothing more than my fingerprints and photograph already listed with the City of Miami Beach Police Department in case they needed to find a suspect. So when we talk and tell our stories, it's traumatic because we actually, or I'll speak for myself, I actually relive situations that were near-death events for me. So it's not just telling a story that just happened last night or the night before. These are reliving and retelling very, very traumatic stories, not only for myself, but for my grandparents and uncles and brothers and sisters. So whenever you hear a person of color tell you a story of their lives and the trauma that they have experienced, it's almost like opening up a wound that you have to re-heal, and that takes time. So if it's not supported by the board of directors and placed on the agenda for review biannually or annually, it's a waste of time.
Can I add to that? I think that was a really powerful testimony. Thank you. And I think critically important as white colleagues try to figure out how to be allies and engage in these conversations, to understand what that means. I think that I don't have any data about these minority health boards. I think my question is really, where is the locus of power? And let us be very clear that this is all about power. Race and racism. Racism is a construct to keep people out of power. If we're going to create equity, then it means that we equilibrate power. And so if this minority health board has power, great. But if they don't have any power, if they're just there for window dressing to say we have Black people and brown people and all these other people kind of talking about their experience and we've listened, but we haven't done anything about it, or we haven't given them the tools that they need to actually enact change, then it's just window dressing. And I would say that part of the reason I wanted to bring this up is not just about these boards, but as I think about what's happening in my own institution, every department now has a diversity chair. Every division has this. And it's like, where's the power? And that makes it, maybe not in this case, but in so many other cases, it still makes it our problem. And it's not my problem. It's not my problem to fix. It's not my problem to make this institution not racist anymore. And I think that fatigue and that trauma that you're describing, Jeffrey, I mean, that's what we have to live as we go to these meetings and events and have to, testify and make everybody else feel like they've, heard something. So I just want to be mindful of that, because I do think that approach of having a minority health board as opposed to a health board, can replicate itself in all kinds of ways. And I think we need to be thoughtful of that as we move forward in trying to redistribute power.
The one comment I would add, which is aligned with both comments, is that the leadership, which is essentially, but we were talking boards, but I don't know if it's above and beyond, I don't mean structurally, but any leader in an organization, whatever the role is, if we're not seeing it and hearing it from the leaders, the official leaders, then it doesn't matter as much that you have it, sort of what Zara was saying about there are all these DEI representatives cropping up in organizations, and people are really good at wanting to appear to be non-racist. But if you look at the leadership, the executives and those who are making the decisions, those boards aren't changing. And so you add in a person of color and say, okay, that's it. But you're still making the same decisions in the same way, using the same standards. And so it's leadership. Boards, yes, but even if you're not on the board, if you're a CEO, CFO, whatever the title is, these titles where the buck stops, as they say, those individuals need to be committed. And it's insufficient to put your statement out there. I mean, all these organizations and corporations that here's my anti-racist statement during this time, they put the statement out. And then what? They don't demonstrate. There's no demonstration of commitment. And so when we talk about being anti-racist, there's action associated with that. And so if I don't see the act, where's the action? So it isn't sufficient to have a statement or to have a board, but what's actually happening in the organization around leadership and the workforce? Adding one person of color or two people of color doesn't change the culture of the environment, because you still have those formal and informal protocols and practices and languaging and things of that nature. So, I mean, it has to be at all levels, I think.
Thank you all for your comments. I know they resonate for sure with me about whether this is it a movement or is it a moment? There's so much attention right now, but it's sustainable. Like, are you putting in these efforts, and are you going to continue to pay attention to it and put in initiatives that really do make change? So I'd like to just do one more question from Shanta, which I think is a nice wrap up for us. She says, we know the historical role that policies have played in contributing to what has resulted in enormous disparities in health outcomes. What are some policy recommendations at all levels that you all think are necessary to start to dismantle the structural racism that we see, so that 5 years from now, we're not having the same conversation?
I personally think that one of the biggest things that we could do would to disassociate school funding from location. I think that could have a tremendous impact in a very short period of time.
Karen, do you have any thoughts on that one about policy?
I was trying to give other people a chance, but yes, I have something. I'll use an example in my response. So we think about affirmative action, and there are many people who support it, many people who don't support it, but people tend to think of affirmative action as a way of getting more Black and brown people into an organization. But if we really look at the data, and this is not to say that women are less important than groups of color, those sorts of things, but policies can, on the face of them, appear to be effective. And we read the languaging and we think this is going to bring about this change. But oftentimes, those who are creating and developing and sanctioning the policy, it's just as we've talked about with clinical practice and all other aspects. If you're not involving the people whom you intend to have the positive impact on, the policies aren't going to be effective. We have to dismantle white supremacy, this notion that white people, the construction of whiteness is oppressive, and we need to be able to name it and understand, well, what does it mean? We're just beginning to name it now. So, these tiny steps that we're taking, perhaps, hopefully, as Dr. Cooper said, we'll continue to sustain them, but we need to be able to look at the way in which policies are constructed in this country in general, or within your healthcare organization. Find out, how are policies developed and implemented within your organization, and who are the people at the table when these policies are being made. So it's insufficient to establish a policy that's going to be handed down for and about a population without having representatives from those communities and those populations at the table legitimately, not just sitting there, but involved in guiding the steps and knowledge and education. I can't speak for all Black people, absolutely I cannot. But I would certainly rather speak for Black people than to have someone who has no idea what it's like to wake up in the world every day as a Black person and experiencing racism. So I think that it's really important to hear those voices, just as Dr. Garland gave his testimony about his experience. I'm sure there's some people in the audience who are saying, I can't believe, that happened. But many people who look like me experience those. It's like, I can certainly relate to it. It's real. It happens in my family on a regular basis. Things happen to me. So people are still having these experiences. So as we're creating policies, I would suggest that we not create policies in the absence of the specific populations and people that the policies are intending to impact.
Thank you for that. I just love to give Jeffrey and Dara one last chance before we go to our take-home points. If you guys want to share.
Because I'm fairly new to the committee and I want to come back and revisit, I'll be somewhat mindful of my tongue. I recall 3 or 4 years ago, out of the state of Texas, the Texas Supreme Court wanted to throw out affirmative action. And yet for education and admitted to higher education, but yet we see a situation in California. If you could buy your way into an institution, you could bypass the regular line, and privilege can get you into an institution, as opposed to affirmative action can keep you out. So my answer to your question is, we need to recognize where power is and expose where power is being misused to admit the privilege and keep out those who are just as deserving or more deserving than those who don't have the funds or the power.
And I really agree with Dr. Karen. I think we need policies that address inequities at its core, not just a sidebar. We need to include everyone that would be affected, and those that can effect change: politicians, pharmaceutical companies, community leaders, doctors, physicians, nurses, anyone that can help to bring about policy change and include the communities that are being affected. They're the one that we're going to get the most information from that would help us to change policy, create policy change that would address inequities. So I think we need to do this and do this the right way, with everybody involved being, everybody that we want to create a change for being involved, everyone. And creating this environment that everyone wants to create that kind of change.
Thank you so much. I want to just take the time to just thank all of the panelists today. We do have a few key take-home messages that we'd like to wrap up with. Again, just emphasizing the need for comprehensive data to better understand the ongoing impact of COVID, as well as the recovery efforts. That's so vital. We want to also emphasize the importance of social determinants of health being at the core of health policies, as Dr. Cooper talked about in her presentation. We encourage people to continue to learn about the role of palliative care and healthcare providers in general in addressing these inequities. And CAPC has a blog series that I'd refer people to check out. Next slide. For spiritual care, we ask that everyone continue to screen for those spiritual care needs. As Dr. Garland mentioned, mental health right now is of utmost importance. It had always been, but even more so now. We want to, again, acknowledge that there may be hesitancy around the vaccination because of historical injustices, as well as ongoing medical issues as well. So just continue to be thoughtful in your conversations and understand that this is going to take some time. We encourage people to create a diversity or equity committee, again, as we mentioned, but not just for face value, but a true committee where the perceptions of the people involved really are highlighted and will be heard and implemented into the policies. Or if one already exists, join it and have your voice be heard. And then our last call to action would just be that everyone speak up publicly about racialized violence and systemic racism. And so again, thank you to the panelists, and I'd love to turn it back over to Dr. Tulsky.
Brittany, thank you so much. I want to thank you and all four of our remarkable speakers and panelists for just a truly extraordinary presentation. I will just say that if you see in the questions in the chat, as well as I've actually been getting separately a bunch of emails, people saying that this is one of the most informative events or presentations they've seen on this topic in the last year. So I want to thank everyone for really a superb presentation. And I just want to add sort of one last take home that I had, maybe it's two. It was said, I believe it was Karen, that it's not race that's the social determinant of health, it's the response to that race, which is racism. I think that is a centrally key concept, and that then we need to think about the effect that racism has on all of our colleagues you know, and so all of us, no matter who we are, that's the place where we can start and think about and take action tomorrow. And there's so much more that has to be done, but that's something we can do right now. And I think that was just a really powerful take-home message. So what I'd just like to say is that all these materials are going to be archived, the webinar, the recording, as well as the slides and so forth, and it'll be available in several business days, probably sometime next week. So just check out that site. And then the last thing is, I believe we have a slide with a number of resources to think about these and other issues related to COVID-19. So on behalf of National Academies, I'd like to again thank all of you, as well as all of our attendees who came today and participated in your questions. We have a lot of work to do, and let's move forward.